Good morning, friends from the Netherlands. That's where I am today. I'll thank Dr. Manoria to invite me to this interesting conference on recent advances. The topic given to me is uh, what's new in hypertension management in the year 2025. And what I'm going to talk to you is on multiple issues that has been developed. There are now new strategies for diagnosis and detection, new guidelines. There have been also technological advancements in adherence assessment and interventions. What I'm going to talk today is on medicines, on interventions, on obesity intervention, and of course, the cardiovascular disease risk reduction. We all have multiple choices available for treatment of hypertension in our country. There are first-line choices like diuretics, multiple forms, calcium channel blockers, ACE inhibitors, ARBs, and beta blockers. And we also have a number of supplementary first-line drugs. Then there are second-line choices like inhibitors, alpha blockers, sympatholytics, vasodilators, and new drugs. The European Society of Hypertension has given guidelines on optimum management of hypertension using a step care approach. And I believe that these are very good for our country because I think what we need to do is to focus on these particular guidelines so that we can treat our patients well. You begin with monotherapy in only very few, normally as a dual combination therapy, ACE or ARBs plus calcium channel blocker or thiazide like diuretic. If they're not controlled, about 60% are controlled. If not controlled, you can combine all these three drugs, ACE, ARBs, and CCBs and a diuretic, and you will find that almost 90% people are controlled. And beyond that, I think if they are not controlled by these particular medication in the optimum dosages, you call them resistant hypertension, and then you refer the patient upwards. There are a few drugs which have been highlighted by the ESC 2023 guidelines: steroidal MRAs, loop diuretics, alpha blockers, vasodilators, and also RNAs, SGLT2 inhibitors, and non-steroidal MRAs. We all are aware of mineralocorticoids, old drugs, and we have been using spironolactone for a long time, mainly in patients with heart failure. But I think they are also very, very important in terms of management of hypertension. And the guidelines clearly mention that if the GFR is more than 30, that means there is no advanced kidney failure. You can safely use them, prefer spironolactone. And if spironolactone doesn't work or it causes lots of gynecomastia, you can switch over to eplerenone, which is also available freely to us. And this sort of approach has also been recommended by the European Society of Cardiology in last year's hypertension guidelines, again saying that spironolactone is a good choice in treatment-resistant hypertension as a fourth drug. And if it's not tolerated, you can switch on to eplerenone. Now we have new drugs which are non-steroidal mineralocorticoid receptor antagonists, and finerenone is also available to us now. We are using it in diabetic kidney disease, also in heart failure, and now it has been shown to be of use in heart failure with preserved ejection fraction. But this is a slide comparison of spironolactone with finerenone for hypertension. And there are two trials, Fidelity TRH and the AMBER trial, clearly showing that hypertension lowering is lower with finerenone as compared to spironolactone, but the incidence of hyperkalemia is significantly lower. So they are a safe drug. And what do the guidelines say? ESS 23 guidelines said that these drugs may provide future alternatives to spironolactone in treatment of resistant hypertension. They cause lower hyperkalemia. They're useful in hypertension and diabetic kidney disease, and also useful in heart failure with preserved ejection fraction with hypertension. ESC 24 guidelines do not comment on the use of these drugs in hypertension. We are all aware of RNA-ARB combinations, sacubitril valsartan, which are widely available to us, mainly in treatments of heart failure with reduced ejection fraction and emerging use in heart failure with preserved ejection fraction. They were initially used for hypertension, but after a remarkable benefit in HFrEF, the focus shifted to heart failure management. And a meta-analysis with 10 studies, about 6,000 patients, confirmed that this combination was better as compared to valsartan, olmesartan, or amlodipine alone. It is approved for blood pressure management in China and Japan, but not in the US and Europe. The other drug with which we are familiar is the SGLT2 receptor inhibitors, widely used in heart failure, widely used in diabetes. And now it is class 1 indication also if in hypertension, if you have associated kidney disease, and if you have hypertension with associated heart failure. So clearly, this group of drugs is also an important contribution, important new development in the area of hypertension management, especially if you have these sort of comorbidities. With the success of mineralocorticoid receptor antagonists, the focus on RAS and new pharmacotherapeutic agents have developed, and one of the important ones is aldosterone synthesis. And aldosterone synthesis involves lots of steps from cholesterol onto aldosterone. And this particular compound, baxdrostat, which is a prototype for aldosterone synthase inhibitor, has been developed. And now there are 3 drugs of this class, baxdrostat, balindrostat, and dexpedrostat, and all 3 phase 2 trials have been published, New England Journal, JAMA, and Lancet, and they showed benefit. And the meta-analysis of these drugs, all the phase 2 trials, have clearly shown that they reduce blood pressure on top of existing hypertensive therapy by about 6 millimeters. So clearly, there's armamentarium to be used. They could be used, but I think the limitation is that they are still in phase 2 trials. Phase 3 trials are ongoing, and it is recommended by various agencies that you need phase 3 trials with larger cohorts and expanded follow-up. It will be critical to determining their roles in clinical practice, including long-term cardiovascular and renal impacts. Another new mechanism is the, again, focus on RAS, and you are trying to silence angiotensin using antisense oligonucleotides, messenger RNAs, and small interfering RNAs or cRNAs. We all know Sirenase, which is inclisiran, is a protein molecule which we all use in people with hypercholesterolemia. So this drug is also a same class of drugs. A new one, zilebesiran, is being tried, a new small inhibiting RNA inhibiting angiotensin inhibition. And 2 trials have been published. The phase 1 trial was published in the New England Journal 2 years ago and showed a clear benefit if you increase the dose of this drug. And JAMA published the phase 2 trial in about 700 patients. And what it found was the zilebesiran single injection reduced 150 milligram by 7.3, 300 by 10, and 600 by 8.9. So again, a significant decrease in blood pressure. Surprisingly, the effect of this drug lasts for 3 to 6 months. So you could potentially have a drug which can prolong blood pressure, which has a prolonged blood pressure lowering efficacy, similar to inclisiran. Like inclisiran lasts for 3 to 6 months. This drug also has a beneficial effect for 3 to 6 months. But only phase 2 trials, phase 3 trials will tell us whether to use it or not. Hypertension vaccines development has been going on for a long time. All are focused on angiotensin peptides, angiotensin 1 or angiotensin 2, and they are still in development. It may increase following the technologies that you use in development of COVID vaccines. Don't forget hypertension phenotypes. And I think one of the important phenotypes is the obstructive sleep apnea. Almost 60-70%. prevalence in resistant hypertension according to the US data, and you can easily diagnose obstructive sleep apnea using polysomnography. And CPAP is a treatment of choice. And if you provide CPAP to these patients, the blood pressure, both diastolic and systolic, decreases, and the change in mean blood pressure 24 also declines. So clearly, there's a scope for treatment using CPAP in patients with uh, obstructive sleep apnea and resistant hypertension. Interventional therapies, I think all the cardiologists are interested in, and there are multiple forms of renal denervation therapy. They are hypothesized to treat resistant hypertension permanently also. Ablation of nerves along the renal arteries in the adventitial layer. They have been evaluated in resistant hypertension multiple trials. Initial trials showed promise. The sham-controlled Simplicity Hypertension 3 failed, no benefit, but now the technology has evolved. And these are data from the Simplicity Hypertension 3, which was a randomized sham-controlled study in North America. And 6-month follow-up, there was a significant change in the regeneration group, but it was also there in the sham control. So clearly, at the end of 6 months, there was no difference in office or ambulatory blood pressure measurement between the control group and the intervention group. However, following that, the technology has evolved. Instead of uh, the the delivery devices that were being used, the denervation devices that were being used, the design was changed. It has come to a spiral device now, and there are multiple small studies performed using those particular devices, all showed benefit. On the other hand, even the Simplicity trial, when they followed up the same people for 36 months, it showed significant benefits. So clearly, there was some scope for renal denervation therapy. Now, in presently, how do they stand? Pharmacotherapy, we all know, reduces blood pressure by about 13, 11 to 13 millimeters of mercury using these compounds singly. And similarly, what you see here is that renal denervation therapy also reduces blood pressure by the same degree. So renal denervation therapy basically is an advance in terms of resistant hypertension management, that you have multiple drugs on board and then you want to do something, but pressure is not being controlled, then I think denervation has definite place, in the clinical armamentarium. And now, at least in the European guidelines, both the ESH and the ESC guidelines, denervation has been given an indication of class 2B, which is, I think, a fair judgment in those studies. We don't yet have data we don't have guidelines from the American counterparts. What do they think of this particular therapy in hypertension management? A new exciting focus is bariatric surgery for hypertension. I think for obese people, it could be a boon. Although the initial trial of bariatric surgery was intensive medical therapy for diabetes, not focused on hypertension, showed that the blood pressure was slightly lower at the 5-year follow-up, 134, about 3 millimeter lower blood pressure as compared, almost the same as medical therapy. But then there was a retrospective study on long-term outcomes. Kaiser Group in the US, 9,000 patients with hypertension undergoing gastric bypass or sleeve gastrectomy, and compared with 66,000 non-surgical controls. And what you find is hypertension remission. It means cure of hypertension. Happened in about 14% in non-surgical group and 60% in the surgical group. And the risk ratio was 10. So 10 times more efficacious in surgical group as compared to non-surgical group as far as the hypertension management was concerned. And here's a randomized trial to evaluate efficacy of gastric bypass in hypertension and obesity. Now, these are 12-month data, clearly showing that almost 83% of patients were off medication, as compared to only 12% which are off medication on medical therapies, clearly showing benefit of bariatric surgery in obese people to go get off medication. And this is the 5 year, the final data of this gateway trial just published last year in the JAC. And you clearly see here is that the relative risk was about 5.9. That means people undergoing gastric bypass had a 5.9 times chances of being off medication as compared to medical therapy. Clearly, important new development. But remember, it is used only in people who have body mass index. So the mean body mass index in this particular study was 37. So clearly, only obese people tend to get benefit from bariatric surgery. Now we have new drugs for cardiovascular benefits, GLP-1 receptor agonists, and weight loss and systolic and diastolic blood pressure. And what I did was to collect data from liraglutide, semaglutide injection, semaglutide oral, tirzepatide, and these orforglipron drugs. All of these led to a significant weight loss, 20% tirzepatide, 15% semaglutide oral, 15% semaglutide injections, and all led to blood pressure decrease. More the blood pressure loss, the weight loss, more was the blood pressure decrease. So clearly, GLP-1 receptor agonists also have a role in decreasing blood pressure. And this particular cartoon shows that all these GLP-1 receptor agonists decrease blood pressure as compared to the older drugs, which are not very successful. And finally, we talk of reducing cardiovascular risk in hypertension. What is new? I think we all know how to treat hypertension, but I think we have to move beyond hypertension if we want to reduce cardiovascular risk. Escort lipid lowering arm was one of the first trials to show benefit in terms of if you combine hypertension drugs with atorvastatin here, you see that there was at the end of 3.5 years, there was almost 36% risk reduction in coronary events and total cardiovascular events and procedures. And the meta-analysis of trials showing combination cholesterol-lowering therapy in uncomplicated hypertension. 3 large trials all had Escort lipid lowering arm and the HOPE-3, clearly showing benefit, and the overall benefit in cardiovascular outcomes was about 21%. So 21% reduced cardiovascular events if you combine antihypertensive drugs with statins. And now, of course, we have polypill. So polypill is not only blood pressure lowering, also statins, also aspirin. So three form of actions, and this particular meta-analysis in which I was also a part of the polypill trials, showing that if you combine as compared to the usual care, if you take polypill, and remember 75% of people with on polypill in polypill trial were hypertensive, and there was a 38% lower risk if you are taking polypill. That means multi-pronged cardiovascular risk reduction. And it was not only helpful in myocardial infarction, but also helpful in stroke. And surprisingly, if you have with aspirin, the benefit was much more. Without aspirin, the benefit was not as high as it was in people with aspirin. So clearly, polypill has a role there. So friends, in conclusion, what we have just discussed today is there are new things which have happened in hypertension management in this particular year. We have new medications, especially non-steroidal mineralocorticoid receptor agonists. We can now use RNA ARBs and SGLT2 inhibitors in people with specific indications. New drugs are on the horizon, especially the aldosterone synthase inhibitors, the angiotensinogen small interfering RNAs, and hypertension vaccines some time to come. Interventions are now found a place in guidelines, and the regeneration therapy using new technologies are there. Older technologies like ganglion blockade and skeletal sinus modulation, they are not used at all except in the research surroundings. And especially the exciting news for people with obesity is that both bariatric surgery and the GLP-1 receptor agonist tend to reduce hypertension in these people. And if you lose significant amount of weight, you can get off blood pressure lowering medication, especially if you are obese. And now we have a cardiovascular risk reduction strategies and polypills and statins. Stand your choice there. Thank you very much. Thank you for your attention. Oh, it's not going off.